So what are the features we need to consider when declaring a patient brain dead? So before declaring the patient brain dead, we have to make sure that there are no confounding factors. Next, so what are the features we need to consider when declaring a patient brain dead? So before declaring the patient brain dead, we have to make sure that there are no confounding factors. There are no confounding factors. So what are the confounders for brain death? One is a hypothermia. Okay, so we have to make sure that the body temperature is at least about 36 degrees Celsius. Next is there should not be any sedative drug effect. Okay, sedative drug effect. If patient was on benzodiazepines, then we have to wait at least 5 half-lives of benzodiazepines before confirming the patient as brain dead. Okay, and paralytic drug effect also should not be present. Sometimes when we put the patient on ventilator, we tend to use the muscle relaxants to relax the patient's muscle so that they do not fight the ventilator. So that particular part has to be taken into consideration. So paralytic drug effect should not be present, and patient's BP should be more than 100. If required, vasopressor can be used. Next is the arterial pH should be normal, and PaCO2 in the ABG should be 35 to 45. Okay, 35 to 45. How can it be done? Is basically we can manage it with the ventilator settings. Okay. Next is hypoxemia should not be present. We have to make sure that in ABG the PaO2 is more than 200 millimeter of mercury. For this we can do it with pre-oxygenating the patient with FiO2 of 1 in the ventilator. Okay, in the ventilator. So we have to make sure no confounders are present, and then go ahead and plan for diagnosing the patient brain dead. Okay, so these are the prerequisites which we just discussed. There should not be hypothermia, there should not be sedative drug effect or paralytic drug effect. The BP has to be more than 100. The ABG should show a PaCO2 of around 35 to 45, which is normal, and there should not be hypoxemia. Okay, and then we examine the patient's brainstem reflexes and say that the brainstem reflexes are absent, like Dolce response, light response. Even caloric test can be done to say that there is no brainstem reflexes, indicating that the brainstem is not functioning. We can do a gag reflex also to say that the brainstem, that is particularly medulla, is not functioning, and then no motor movement is present. And then we finally, before concluding, we have to do the most important test, the apnea test, to conclude that the patient is brain dead. Okay, to conclude that the patient is brain dead. This particular apnea test can come as a question. Let's see how to do a apnea test. So these are the reflexes which we have to do before confirming that patient is brain dead. Okay, so I've just told this is a caloric test, the pupillary response or light reflex. Okay, and then this is the corneal reflex. This is a gag reflex which we do usually. And then we have to do the apnea test. In apnea test, we have to make sure that there is no confounder. That is the first prerequisite we have to fulfill. Next, what we do in apnea test is that we have to have a baseline ABG. That is the most important part. There should be a baseline arterial blood gas analysis where the PaCO2 is between 35 to 45. Once the ABG is obtained, then we disconnect the patient from the ventilator, and then we supply the oxygen through the tube, and the tube is placed in the carina. Okay, in the carina, and this is given for around 8 to 10 minutes. During these 8 to 10 minutes, we look for any amount breathing effort, and also we look for any motor response. Okay, we look for any motor response. After 8 to 10 minutes, if there is no breathing response, if there is no chest movement, or if there is no motor movement, then we continue the test, and at around 10 minutes we draw another ABG, we draw another arterial blood gas analysis. So what do we find in this arterial blood gas analysis if the patient is brain dead, or we say that apnea test is positive when there is a rise in PaCO2 of up to 20 from the baseline ABG which we did, or if PaCO2 is more than 60 millimeters of mercury, then we also say that the patient's apnea test is positive. Patient's apnea test is positive. Then we connect back the patient onto the ventilator and discuss with the patient's relatives regarding the feasibility of organ donation. This is how the apnea test is done. Okay, and how do we, other than apnea test, which is a clinical test, how do we confirm the patient is brain dead? We can do an EEG, and in EEG we see something called as electrocerebral silence. We can do an MRI also, specifically MR perfusion can be done to look at the brain activity. We see that there is no brain activity at all. The perfusion images will appear completely dull. There won't be any perfusion, there won't be any signal coming out in the perfusion studies, okay, in a brain dead patient. So this is the EEG of a normal patient here, where we see good alpha and beta waves. Okay, this is a patient with who is brain dead. Here we see we can see some amount of deflections here, but these are all rhythmically present, so they are most likely EKG or ECG artifacts. If you remove the artifacts, then we see a plain flat line. Okay, this is called as electrocerebral silence. Okay, next, when we do MR perfusion, we see that there is no perfusion at all in the brain. This particular pictures are basically internal carotid arteries, which are seen as a bright signal. Okay, and these two images, these two pictures, or these two arrows are basically the perfusion from the external carotid artery, but brain per se will not show any amount of perfusion, which also suggests that the patient is brain dead. Next is, a patient with coma can go on to become brain dead, or they can recover and become conscious. If not, then they can be either in persistent vegetative state. Depending on the cause of the coma, we can divide persistent vegetative state into two. If the trauma is the cause for coma, then if the patient is in a vegetative state for more than 1 month, then we consider it as persistent vegetative state. If the trauma is not the cause and patient is in coma for some other because of some other reason, then we take a duration of up to 3 months before declaring the patient as persistent vegetative state. So if the patient becomes conscious, he can be in minimal conscious state, or they can have good recovery. Okay, if not, they can be left with some disability. So what are the treatment options available for patients who are in coma so that recovery can occur? Some of them are amantadine, methylphenidate, and Syndopa can be tried for improving the consciousness level of patients who are in coma.